all this, but we'll see where we go. Okay, so what are yeah?
What is our exam going for next Thursday?
Respiratory. Yeah. And you got, oh, sorry, that was a good point. You guys all got the memo. It's on a Thursday and not normal class time. Christy updated that for you guys. We have not. No. Respiratory, we'll talk about asthma guidelines. We'll talk about COPD guidelines. That's next. That's Monday. Yep, and then you have exam on Thursday. Yep. I just do what I'm told. I was told that it would get moved to Thursday, so I don't know. Yeah, it was normal. It was supposed to be for the following Monday, but apparently you guys had more exams that day.
We have a Kleinman exam on that Monday.
Yeah, so that's why they moved it. I will post the respiratory stuff early. It's very guideline based, so if you want to get a head start on reviewing the PowerPoints and the guideline slides, that's what the test is going to be on. I'm going to ask you questions about respiratory guidelines, and I can post the cases a little early to give you guys a head start if you want the weekend to review it before the lecture on Monday. Okay. Yep. All right. So with eye-related things, there's a lot of eye drops that you can give people that do a lot of different things. We're going to focus heavily on glaucoma today because it's a major disease state. Excuse me. So we have a couple other things we'll talk about quickly too, though. So dosage preparation is important to understand a little bit about. So you have solutions that are sterile and homogeneous. Eye drops are sterile, so just remember that if you ever give somebody something for an infection or a conjunctivitis, that they shouldn't touch their eye with it, and they should make sure not to share it with somebody. The odds of somebody not touching their eye, slim to none, so just don't. Like spreading it around the family, I guess if everybody's got conjunctivitis, what's the worst that you can do? But giving it to somebody who might not have it, who might contaminate another eye, I don't know. It's just know that they are sterile to begin with, but they don't stay that way for long. Most of them have expiration dates once you open them. They say on the bottle usually. Some do require refrigeration too. Suspensions contain particles. Solutions are homogeneous. Doesn't really matter what they are. Suspensions and solutions, as far as we're concerned, they're all liquid eye drops. They're all going to be dropper form. They're going to feel like a liquid when they go into the eye. For the patient, you aren't going to know the difference between a solution and a suspension. Ointments and gels get different because they're thick. So like an ointment is going to be going to obscure somebody's vision pretty substantially if you put an ointment. So like what we use ointments for, maybe like a lubricating ointment would be good before bed. If you want something to keep your eyes moist while you're sleeping, so you don't have to see. Not during the day because you probably can't really read anything or see where you're going. Gels are going to obscure vision for a little bit of time. They're going to last a little bit longer, but they should dissipate quickly. And the reason why we do it is just sometimes it's the vehicle trying to get a drug into an ophthalmic form that doesn't burn somebody's eye substantially when they put it in. By burn, I mean sting and irritate, not like physically burn. Buffered pH is really important too, so we want to make sure it's close to body pH, and that can help with it too. A lot of times you'll see different formulations come out, so you might see one brand of a drug go generic, and then the drug company releases a modified version of it. A lot of times they're rebuffering it to a more compatible version. Why they didn't release that originally, again, we won't go into that detail, but that's just the way it is. Education is really important, and this doesn't necessarily fall on you guys, but I think it's important for anyone who's going to consider prescribing an eye drop to make sure their patient knows how to do eye drops, because it's not as easy as I think people think. So, of course, you have to get it into your eyes, so they recommend this here. So you look at the ceiling, lower your lid down, steady hand on your forehead, and then try and do it. I don't know, I suck at doing eye drops, so I always get them like on my forehead, but I don't take eye drops regularly for any reason, so whenever I try and do it, if my eyes feel dry, I just miss, and I'm like, it's not worth it. You want to avoid touching the eyeball with the tip of the applicator. Wait 5 minutes between medications if using multiple ophthalmic agents. This is really important if you work with glaucoma patients because they might be on 3 different eye drops. So that's a question you get a lot as well. What order do I give them? Order doesn't usually matter too much. What does matter is the time in between. You want to give that drop plenty of time to absorb. If you do drops really quick in succession, then you can end up with things just washing out of the eye, and then you don't get any effect from your medication. If you're combining ointments and gels with liquids, you want to do the ointment and gel last. And that should be kind of obvious, but again, that's blocking all your absorptive area, so your drops are just going to run right out of your eye if you try and give it over a gel or an ointment that's still in the solid form. Try to keep the eyes closed for 1 minute after instilling. I think they tell patients to do this, hoping you might get 15 seconds, right? Somebody's not going to maybe sit there for a minute with their eyes closed. Maybe they are if they're a really good patient, but most people might do several seconds, and that's probably okay. But if you can do the full minute, great. Store them in a cool, dry place. Again, some require refrigeration. Most of them are okay in the refrigerator, and I've actually heard of patients who like to keep their eye drops in the fridge because they can actually like the cool sensation. It might help, especially if it's not a very well buffered formulation. The cooling sensation might help offset some of the staining, and most of them are stable. So, if they have a question about that, you can always ask a pharmacist or look at the actual labeling on the product and see if it's okay in the fridge. An expiration date. If people aren't using eye drops very regularly, if they're doing like once a day in one eye, their eye dropper will likely expire before they get through the whole thing. So not keeping an eye dropper around for months, because it does lose stability pretty quickly, more so than a regular drug, making sure that they're getting a regular refill on that pretty quickly, because the expiration dates are important with those. Especially if it's a refrigerated product that has been taken out of the refrigerator, usually it'll get might go from 2 years expiration date to 30 days. Writing prescriptions and using ophthalmic specific SIGs can be interesting. I don't know if you guys have gone over this, but just to review, GTT or GTTS is drop or drops. Also, not to be confused, but to be confused with drips. So if you're saying a GTTS, you could either be talking about eye drops, or you could be talking about like a continuous IV infusion as a drip, right? So it's a little bit confusing. But when we're talking about this, you're looking at the whole SIG, so hopefully it's not that bad. O is oculus, OU, both eyes, OD, right eye, OS, left eye. There's a big move to get all these removed, and actually a lot of the safety groups say that we shouldn't even be using these abbreviations anymore because they're confusing, and they are. They're Latin, people have to remember, okay, it's D, dexter, that's right. How do I remember that? Left-handed people are sinister is the way that I remember OS, but that's whatever works for you guys. So an example of how you'd prescribe this or write this: instill 1 to 2 GTTS, OU, QS, PRN. That'd be 1 to 2 drops both eyes at bedtime as needed. So just, for example, if you're wondering how you write these out, you can always just write it out in normal English if you don't want to confuse people. I find that a lot of times people mess up the eye, and a lot of times people don't put the specific eye on there, and I'll ask the patient, they're like, oh, I'm using my right eye, and it says both eyes in the chart. So that's something that is probably the most common problem, because a lot of the times they'll just default. So if you type in a prescription, it might default to both eyes, where actually they're just doing it in their left eye. So just make sure you're double checking those types of things. All right, very quickly talking about procedural things. If you work emergency or urgent care, this is something you probably have to do. So we have a couple ways we can use eye drops procedurally. Local anesthetics is the first one. So this would be foreign body removal or prior to surgery. I'm not sure how much PAs get involved with ophthalmic surgery. Maybe you guys do. I don't know. I don't work in that area, so I really have no idea. But if you do, you can use different cane products. We'll talk about cane products off and on here and there. But anything that ends in cane is all pretty much the same thing. It's a topical anesthetic. Lidocaine's the most common one. We use it for a number of applications. But there's a drug called proparacaine or Alkaine, which numbs the eye. So if you're removing a foreign body, this is what you're going to use in an urgent care type setting. You use a couple drops. It blocks nerve impulses, and it's a sodium channel blocker. So it works locally on the nerves and prevents pain impulses from being transmitted that way. Lasts about 25 minutes. So once your procedure is done, you should have adequate window there. You aren't supposed to repeat use on it. You can cause permanent damage over time. So it's really just a short term. It's not like something somebody should be taking on a daily basis by any means. That would be inappropriate. Anticholinergic medications are going to open up the pupil, so causing mydriasis. Remember, that's one of our anti-dumbbells effects. So dumbbells, meiosis is one of them, mydriasis as anticholinergic. And there's a lot of different options. They all pretty much do the same thing, and a lot of it is based on the duration of action. So, for example, there are atropine eye drops out there. However, they last a really long time. So if you gave somebody atropine eye drops, they're going to be pretty much blind, well, vision impaired, we'll say that, for the majority of the day. Cyclopentolate and tropicamide are probably the two of the more popular ones. They're just shorter acting. They only last for maybe an hour or two versus several hours. So when you're doing a procedure, you usually don't need more than a few minutes or maybe 30 minutes of mydriasis going on. So why do we need a drug that lasts more than a couple hours? So we want to use the shortest one possible. Cyclopentolate's usually the drug of choice there, but they all pretty much do the same thing.
What was the second one you said?
Tropicamide is another one that I see used occasionally. In our ED, anyway. Anti-allergy. So we do have some other ENT applications here for allergic symptoms that are related to ophthalmic, ophthalmic symptoms. You have mast cell stabilizers and antihistamines, but these are mostly BID dosing. So you have two pretty much common drugs here, and then some other ones that aren't really used. So cromolyn we talked about comes as a nasal spray, also actually comes as an eye drop, rarely used. The two big antihistamines are olpatadine and ketotefin, or Patanol or Zatador. I think ketotefin is over the counter. Can't remember if Patanol, is Patanol gone over the counter?
No.
Anybody know? No, it's not. Okay. I thought they were trying to get it over the counter. I wouldn't be surprised if it is eventually. Patanol comes in two different forms, Patanol and Pataday. Same thing, slightly different formulation. The Pataday lasts longer. It's not really a gel. It's more of a longer-acting suspension that I don't know if it just doesn't get washed out of the eye quickly. I'm not exactly sure how they make it last longer, but it does seem to stick around longer. And they're just antihistamines for allergic conjunctivitis. The other two drugs on there, I'm not too concerned. You know, they aren't super common, but they're the same thing. They're just antihistamines. So short-term usage, when you're talking about anti-allergy and ophthalmic preparations for temporary itching, you also have some vasoconstrictors you can use. So these are going to be the common over-the-counter products like Visine type products. Although you do have to be careful because a lot of those brand names will put different stuff in there. So you might buy a Visine product and all it might be is a lubricating eye drop. So you have to actually look at what's on the back of it. Tetrahydrozoline, I think is how you say that, is the common one for Visine. It's related to oxymetazoline, which was Afrin. So they're all kind of the same thing. They're alpha agonists. These ones are just formulated for eye use. So you'll see different products use naphthalene is a common one as well. If people have narrow angle glaucoma, which we'll get to, these are absolutely contraindicated. They can make it much worse. Lubrication, there's tons of products out here. They're all over the counter. There's lots of different uses, or lots of different formulations, gel solutions, ointments, really just patient-specific preference. There's no right or wrong answer here. Lots of brands, like Refresh has 20 different products under its name. So lots of times, like in the hospital, we just have a single product we give people. We have an ointment, we have a gel, and we have a couple eye drops, and that's what you get. You don't really get to choose your specific Refresh thing. So they all really do the same thing. Most of them are various insoluble alcohols or like carboxymethylcellulose, so like an insoluble cellulose chain. Sometimes they might be as simple as like sodium chloride or glycerin too. You might see those types of products. Not really lubricating, but kind of the same idea is cyclosporine. So we talked about cyclosporine during immunology and with respect to transplant medicine. It's the same drug here, and it's used in an eye drop form, and it's designed for chronic dry eye. So the idea is that people have this thing called keratoconjunctivitis, sicca, which is some dryness caused by an ocular inflammation, thought to be some sort of immune-related local reaction going on, autoimmune-related local reaction. So you get foreign body, excuse me, you give Restasis or cyclosporine to treat this. Restasis has some interesting effects too. It can cause swelling, cause the feeling of having a foreign body in your eye, stinging sensation, burning, and pain, which sounds like a great drug to take if your drug's dry. Eyes are already dry, but a lot of people take Restasis, so it must work to a certain degree. It's a twice daily medication, and it's an interesting presentation, because it comes as these packets instead of like an actual bottle like most eye drops. So each packet is single use. So every time you use Restasis, twist off a little thing of plastic and put it in and throw it away. Some patients actually find that a little easier to use than a traditional eye drop, but personal preference. Ultimately, it stimulates tear production, and it's thought to probably suppress inflammation going on as well. But, for chronic dry eyes, this is really the only drug out there other than just using regular lubricating drops constantly throughout the day.
Is this something you would get diagnosed with a condition?
Yeah, I'm not sure what the diagnostic criteria are specifically. If you have to have dry eyes for a certain amount of time or not refractory to lubrication, that's a good question. I don't know. Bacterial conjunctivitis, usually looking at Staph aureus, strep pneumo, H. flu, MCAT. Chlamydia can also cause this as well. Lots of antibiotic products on the market. They all pretty much cover most of that stuff, with some exceptions. There's not really a lot more to say about it. We talked about this a little bit during infectious disease, so there's just options there that are available. Most people probably use fluoroquinolones because they're the more broad spectrum ones. Some of them come as ointments as well. The ointments might have a little bit better activity because they stick around longer, especially maybe around the outer edges of the eyelid. But it's whatever you think works. There's not really a right or wrong answer or choice here. Okay, glaucoma. Glaucoma is characterized by two major things. So there's open angle and closed angle. Open angle is the one we think of as the chronic disease, the one you're going to manage regularly with multiple eye drop regimens. Closed angle is an acute, and it's not life-threatening, but it's eyesight-threatening cause of blindness. And if you don't treat closed angle glaucoma quickly, somebody will go blind. It's a really increase in intraocular pressure. Excuse me. Really quick increase in intraocular pressure. So for places that don't have good access to medical care, it can't get in to get treatment or see an ophthalmologist in time, it's a leading cause of blindness worldwide because of that. So, but just to know those two differences. When we talk about glaucoma, we're going to focus mostly on open angle. So this is a drawing I found on Google Images, or a picture about like what glaucoma might look like. So you might get slowly kind of blurring of the edges of your vision, and then ultimately you get kind of constriction of your vision, so you're almost seeing tunnel vision. The reason why this happens is because for some reasons, there can be a number of different symptoms that lead to glaucoma. A lot of times it goes hand in hand with diseases like long-term hypertension and diabetes. But you get slow clogging of the drainage canals, increased intraocular fluid pressure, which puts pressure on the optic nerve and ultimately causes vision loss over time. Closed angle is the same thing. It's just a different mechanism. It's just going to put, it's for some reason the drainage canal got completely blocked, and you get a really sharp increase in intraocular pressure, causing a severe push on the optic nerve. So you get a lot more damage, whereas closed or open angle is much slower and gradual. If you have open angle, you're at higher risk for closed angle, possibly, but you can get closed angle for no really good reason, from what I understand too. This is definitely a medical emergency. So again, talking about two very different treatment strategies here. And just a drawing explaining what I just said. So the way we treat glaucoma is we lower intraocular pressure pharmacologically. So there's a couple different drugs we can use, and they all do one of basically two things. They're either going to increase aqueous outflow, so they're going to get rid of fluid, or they're going to decrease production. And that's how they break down. You notice that alpha agonists actually do both, so they have a dual mechanism there. But you can combine drugs based on these different categories, and really you can combine them. It doesn't really matter if they do the same thing. So like you do a prostaglandin and an alpha agonist, and you're going to get synergistic effects. So it's really just class-based is how we treat this. One drug from each class is usually how you approach it, and we'll get to that here in a second. A lot of the treatments, because the products aren't buffered very well and can't be buffered very well because of the stability of the actual drug, you end up with a patient who's got dry, red, or irritated eyes. That's unavoidable in a lot of cases. Certainly lubricating eye drops can help with that. Tachyphylaxis is also something common. You guys talked about that terminal. This means you've used something a lot and it stops working. So that's not uncommon with glaucoma, that you've had a good response to therapy for several years and all of a sudden their intraocular pressure is going up and you can't control it. And you're like, what's going on? What changed? Nothing. That's what happens sometimes with this treatment. Cannabis, I'm gonna have you guys do a kind of self-learning module next spring about medical marijuana in Minnesota and nationwide. So you can read all about glaucoma and cannabis if you want, but I'm gonna show you that there's a lot of other treatments out there other than cannabis. Certainly, cannabis is one of the acceptable uses of glaucoma in Minnesota. Glaucoma is one of the acceptable diseases for medical marijuana in Minnesota right now. So it is something that has some evidence with it, but I think we have a lot better treatments than cannabis. If you last line, nothing else maybe, but there's of course other options too, laser therapy, surgery options that I'm not going to get into or talk about. Okay, beta blockers are our first drug. So we're going to talk about beta blockers a lot more extensively during cardiovascular medicine. But these are beta receptor antagonists. They're going to work specifically in the ophthalmic area, of course. And the ones I bolded are the ones that are more common. What I would recommend you remember a beta blocker by is the last 4 letters, is the OLOL. That's would enable you pretty much to recognize any beta blockers. There's no other drugs that are really spelled that way. So if I give you Timolol, you should be able to recognize instantly that that's a beta blocker. Beta blockers have usually twice daily dosing. There is a Timolol gel product out there that's once daily, but most of them are morning and night. They're all non-selective for beta receptors except for Betaxolol, which is beta 1. It doesn't matter. It's not clinically significant, so don't chalk that one away. I just pointed out there because when we just talked about receptors, we're moving on to talking about drugs that work on these, and within the ophthalmic treatment area or treatment world, we don't really care what beta receptors we're working on. It seems to be not exactly sure which beta receptors are important, but most of them are either 1 or non-selective, so likely is 1 that we're targeting here. But the point is that these are just staying in the eye, and so you really don't get any systemic side effects. However, some people do report that you get changes in cardiac conditions is a possibility. So maybe over time, using the eye drop chronically, you do get some long-term beta blockade that's happening systemically from the eye drop. It's possible. Normally that'd be synergistic to a lot of cardiovascular complications, but it could be problematic. And when we talk about asthma and COPD, I'll mention it briefly now and then, but when you have somebody on something that's blocking beta receptors and it's non-selective, so if it's blocking beta 2 receptors in the lungs, that prevents a lot of our medications from working properly. Our medications are beta 2 agonists. They open up the airways via that mechanism. So if you're blocking those receptors, it can be a problem. It can interfere with how we treat asthma and COPD. So just something to think about. Again, that's odd. You wouldn't really expect to see that effect from giving somebody eye drops, but it is theoretical. They do lower intraocular pressure by about 20 to 30%, so they're highly effective medications. Historically, these were always first line. However, they have taken a backseat to prostaglandin analogs. So prostaglandin analogs are listed all up there. These are all really commonly used. You'll see all of these brands pretty regularly. I think latanoprost is the only one that is generic, so it's the cheapest one out there. The rest are all brand name. These are all once daily dosing, which is convenient. They're all somewhat expensive, with the exception of latanoprost maybe being slightly cheaper. They all prostaglandin analogs, so we just talked about those a little bit. No real side effects to speak of, except for brown discoloration of the iris, which is irreversible in 15 to 30% of patients. So somebody has blue eyes, doesn't want to lose them or risk losing them, it is possible that you could get, you don't necessarily get like a full blue to brown thing, but you can get a slight discoloration up to a substantial discoloration for these medications. Some people might like this side effect. It lengthens and darkens the eyelashes, and this is actually a cosmetic product called Bimatoprost or Latisse, which you might have seen advertised on TV. It's the same thing. It's an eye drop that's a glaucoma drug, basically, that they're marketing for cosmetic purposes. No difference there. The only difference is you don't actually use that drug for glaucoma. So they don't cross over, even though it probably would work. It's just not a product used for that. It's only cosmetic. Systemic effects, none of significance. Lowers intraocular pressure by 25 to 35%. It's the most effective drug class we have, and it's the modern first-line therapy. Compliance is better, more effective, less systemic risk of side effects. It's just that discoloration that's the big kicker for some people. So that's going to be an effect some patients will want to know about. Certainly don't want to give your patient something that changes their eye color and not tell them about it, right? So just keep that one in the back of your mind. Alpha agonists. So brimonidine and apraclonidine are the two alpha agonists. Brimonidine is the only one that's used for chronic therapy. Apraclonidine's got some different kinetics to it, and it is useful for closed angle glaucoma. It's a potent drug that's useful for opening up channels quickly. But for general glaucoma, daily use, it's not appropriate. These drugs are twice to 3 times daily, so a little bit more frequent. They're alpha-2 specific, and they reduce the production and they increase outflow as well. So remember, they have a dual mechanism. They're the only class that does that. Thought to be probably the most irritating eye out of the 3 major groups. Systemic effects, you have maybe some issues with hypotension. Remember, alpha receptors in the peripheral vascular system. If you're causing different alpha agonists, you can cause vasoconstriction, which can increase blood pressure and also cause postural hypotension in some patients too. It lowers intraocular pressure by about 18 to 27%, similar to beta blockers, not terribly different. Alternate first line, more likely a second line therapy. Some people there's some thought out there in some maybe animal models that show that brimonidine has some neuroprotective effects with respect to the ocular nerves, so it can actually maybe help reverse disease or preserve current function, where the other ones are really just reducing pressure. This one actually might have some future neuroprotective effects, but that's debatable. Less popular drugs. So those three are really the big three classes you're going to use in clinical practice. These ones we're getting into the weeds a little bit, but you do see these used occasionally. Brinzolamine and dorzolamide are two carbonic anhydrase inhibitors. And the way carbonic anhydrase inhibitors work is this nifty drawing over here. So carbonic anhydrase is an enzyme that converts water and carbon dioxide into bicarbonate and hydrogen ion. So what you get is a reaction that is going to cause a shift in concentration gradient, and therefore fluid is going to follow. So water is going to follow the carbon dioxide via the system. If you block this enzyme, what you can do is change your concentration gradient, and hopefully you can pull out some of the fluid out of your cell. That's the theory behind this. These don't work as great as other drugs, they're worth a shot. Sometimes they have decent effects for some patients. It's probably an adjunct therapy at best, so maybe like a third or fourth line type thing we're talking about here. There's not a lot of side effects, so that could be an advantage to using them, especially systemic-wise. There's really nothing to be concerned about. But they are like 3 times a day, so it's not the most convenient medication out there. Cholinergic medications are rarely ever used. The reason is they cause fixed small pupils and people can't see very well, which defeats the purpose of treating glaucoma, in my opinion. Systemic effects, you don't really get much systemic absorption, which is great. They do lower intraocular pressure quite well, but this would be a last line option. So I don't recommend them unless you really have nothing else to do and your patient doesn't need to see very well. Or maybe you have a patient who can tolerate the vision changes. It's possible, but most people will get myopia and pinpoint pupils on it, which isn't going to help them all that much.
Don't the first 3 don't really have that many side effects.
Right, yeah, we're talking about ophthalmics. When we talk about systemic side effects, it's minimal side effects, yeah. Most side effects you're going to get are burning and stinging, and then the brown discoloration with the prostaglandins. Those are the big ones. But, people with fragile cardiovascular conditions, they get concerned when you do anything that's going to maybe upset that balance. So the possibility of an alpha agonist or a beta blocker getting systemic when you don't want it to could be significant in some patient populations. Not likely, but it's possible. Combination therapy, there's a couple ones that come in combination bottles. So there's Combigan and Cosapt, and they both combine Timolol with a carbonic anhydrase, Cosapt combines Timolol with dorzolamide, the carbonic anhydrase inhibitor, and Combigan is Timolol plus brimonidine, the alpha agonist. And you can see that there's a nice ad campaign that apparently, I don't know if a lion's supposed to be glaucoma, and then you're taming the lion by taking. It's a stretch, I think. I think whoever came up with that one, I don't know where they went to school, but maybe not the best ad campaign I've seen. All right, so how do we treat this? You diagnose glaucoma. You've done whatever test, where you blow air on the eyeball or however that works. I don't know. Not my area of expertise, so I'm going to plead ignorance on that one. And then you diagnose them. So they have raised intraocular pressure. You need to treat them. Start with monotherapy. You don't ever really have a reason to start with 2 eye drops right off the bat. Especially if a patient's new to taking eye drops, you don't want to overwhelm them too much. So prostaglandin is going to be the choice for most patients. If your patient has blue eyes or green eyes and they don't want that risk, beta blocker would be your second line. And then 2 to 4 weeks is about the time you're going to look at for an adequate response. After that, you're going to say, okay, well, your intraocular pressure has gone down a little bit, but maybe not enough. Sometimes you can increase concentration, like specifically with the beta blockers and alpha agonists, there might be variable concentrations. Prostaglandins are pretty much a one-shot deal. You could try a different prostaglandin in the class, but the odds of you getting better success with that are probably pretty slim. But compliance is a big one. Make sure they're taking it every day. Are they taking it appropriately? Are they closing their eyes for a good amount of time afterwards? If they're using multiple eye drops, Are they using a lubricating eye drop right away afterwards? Make sure you're asking those questions, because this is an area, this isn't just taking a pill, which is really easy for most people to do. This requires a little bit more skill, and there's a lot more room for error for the general patient population. So that's an important thing to ask. Intolerance would be the next one. So what's the intolerance? Does it sting them? Does it burn their eyes? Is it just annoying because they have to do it 3 times a day? What's the intolerance there? Okay, so your next options are increased concentration, assuming compliance and tolerability aren't really issues. If tolerability is an issue, try switching formulations. So maybe Travatan is a good example. It's just Travatan and Travatan-Z. Travatan-Z is buffered differently. Maybe you switch it to that brand name product versus the other one. Anyway, let's say you started them on Timolol and it didn't work. Well, switch it to whatever other one you have available. So try prostaglandin, try alpha agonist. Either one would be fine. And again, it depends on the person's eye color probably. And I'm not saying you can't use this in people with blue eyes. And in fact, if you get somebody who's risking losing their vision versus losing the color of their eye, that's probably a good decision to make, is to actually put them on the prostaglandin. It's going to help them in the long run. And ultimately, if their eye color diminishes a little bit, it's better than them losing their vision, in my opinion. But patients might get upset about that. So that might be an honest conversation you actually might have to have with somebody at some point in your life. But anyway. Adding on additional therapy is okay. You're going to add on another agent, 2 to 4 weeks, and reassess. And really where we're going to get at is if we're going to add or switch is how much effect you're getting. Are you getting a reduction in intraocular pressure from baseline? If yes, add on. If not, switch agents. If you're not getting any effect from the drug, there's no point in keeping it on. Okay. If somebody's intolerant, let's say it's really burning their eyes a lot, you could consider decreasing the concentration, changing the formulation. Switch within the class. Sometimes maybe one beta blocker burns, another one might not. Definitely try that. And 2 to 4 weeks and reassess that. Ultimately, you're going to continue that trial and error process until your safety and efficacy goals are met. So people might end up being on three of the, all 3 primary agents. They might be on a carbonic anhydrase inhibitor. The carbonic anhydrase inhibitor might not be a bad choice if you're combining it, like giving them a combination. Maybe compliance is a big deal for them, so the Betagan product or the COSAP product might actually be more useful for them than maybe another patient. Even though we don't use carbonic anhydrase inhibitors by themselves a lot, in combination it might be effective for certain patients. All right, we'll talk about closed angle really quick because I don't have a ton to say. Again, eyesight-threatening emergency, we are treating them empirically until they can get an ophthalmologist to see them and probably perform some sort of surgery or procedure. I'm not even sure what they do, but in the meantime, you can keep the eyesight healthy-ish for the time being by applying some eye drops quickly. So usually what we do is we give a rapid administration of Timolol, aproclonidine, and pilocarpine. So we're using cholinergics, using alpha, and we're using beta blockers. Why those drugs? They're pretty potent, and we don't care about the person's eyesight. Cholinergics are quite potent and they work well. In this situation, they work fast, so it's a nice choice. The prostaglandins generally don't have a very quick onset, so in acute treatment, they don't have as good of a role in therapy. So even though they're effective for long term, not useful in this situation. Systemic medications, you can give PO acetazolamide, which is a carbonic anhydrase inhibitor, to help with that concentration gradient. And I've never seen this done, and I've seen a lot of cases of closed angle, but you theoretically could give somebody like a big bolus of something IV called mannitol. And mannitol is an insoluble compound that basically just changes concentration gradient. So what it's going to do is pull fluid out of the eye. So that's all it's really doing. Not much more to say about that. And finally, macular degeneration is something that comes up. It's a age-related disease that affects most people. Best way to avoid it: stay healthy, control your blood pressure, control your diabetes, get regular eye exams, and wear sunglasses. If you do get macular degeneration, there's 2 different types: dry and wet. Dry is a slow progression over many years, heavily associated with smoking. Wet can usually develop from the dry form, and it's a sudden, rapid progression of macular degeneration. And normally for macular degeneration treatment, there was some study out that the specific eye formulations, if you ever hear people taking Preservision or Ocuvite or any of those types of eye, this is what it is. It's a CE, beta-carotene, and zinc. It's a multivitamin just with less stuff in it. There's nothing special about it, even though lots of patients take it that way. It's just, I don't know, I think it's bogus personally. Anyway, laser therapy can help with dry type. Also with wet type, you're looking at an intravitreal injection. We use drugs that I think I talked about Avastin during the chemo lecture a little bit, but you actually inject it into the eye. If you want to look at videos that scare me personally, I got a YouTube one on here. And you do it once a month and then every 3 months for there. So there's two different medications, Avastin and Lucentis, both insanely expensive, but it does improve eyesight. They do work quite well. So you can do steroids too, but the first two drugs up there, the vascular endothelial growth factor inhibitors, those are the big guns when it comes to wet macular degeneration. That's going to be an ophthalmic procedure. So that's super important to this class, but just something to talk about, I think. And that's it.